So this is a case about the nice patient sign and some interesting findings that came along with it, and then discussions and sort of lessons and things that we don't maybe teach or think about as often as we should in medicine. So we start with the board review question. 72-year-old white female evaluated about 2 weeks ago for hemoptysis, weight loss, diagnosed on biopsy with non-small cell cancer. In addition to a rather large lesion in her lung, bony metastases in the liver seen on cuts through the abdomen. Very good functional status, lives home alone, has some support from family, otherwise doing well. No other chronic medical problems, never smoked, clean living. Unremarkable exam otherwise. No distress, interested in life-prolonging therapy, understanding even though that she has what's considered to be stage 4 cancer, learning in kind of what her options are. So the question is, when is the most appropriate time to begin discussing palliative care options with this patient? So now, when the patient becomes more symptomatic than just a bit of hemoptysis and weight loss, when the patient's oncologist recommends referring for hospice, or when the patient decides that at some point they no longer desire life-prolonging therapy. Anybody want to hazard a guess?
Say now.
Yeah. And why now?
I mean, it's a terminal illness, and even if they won't prolong therapy, they're going to have to cross that bridge at some point. So. Absolutely right, Nelson.
So, if someone has a terminal illness, especially one that seems to be fairly advanced instead of just being terminal in a longer sense of the word, it's absolutely important to get them on board ahead of time so that as they progress through their disease and at some point maybe they're not able to make their own decisions as well, they lose some of that independence and functional status, that this is something that's been discussed and thought about ahead of time.
So just to add on to that, for Medicare now they have guidelines of things that should be covered based on age and diagnosis and things like that. And for elderly patients, advanced planning and functional status are things that are measured. So those are actually care measures as well.
And fairly recently, as of earlier this year, I think Medicare made a change in their rules that allows billing just for this specifically. It's not just a care measure, but it's something that actually we can get paid to do now. So our patient in particular, chief complaint, she's had common ground emesis for a week. It's an 88-year-old black female, history of hypertension, diabetes, GERD. Came home from Aruba with her niece after having some of this coffee ground emesis. A little bit dizzy, nauseated, not eating well over that time. Some lower extremity swelling. Came straight from the airport to U of L's ER, and has had fatigue over this time as well. So this patient was admitted overnight. No other significant past medical history. At this age is really doing quite well functionally. Had a history of stomach ulcer a long time ago, no problems with that, and some other mild issues, but really has done pretty well with her life. As far as allergies, none. A few medications, not bad for someone of this age. No other real significant concerns. So, on exam, the most significant things, a little bit tachycardic, but really nothing significant. So of note, on the overnight exam, it was noted that the abdomen was fairly normal. When we examined the patient in the morning, found that her belly was just a little bit distended. She had kind of a generous liver on exam, and was obviously a little bit tender, but really it seemed a little bit out of proportion to maybe what was going on for a lady of this age. So, as far as the summary goes, we have a patient who's had a week of coffee ground emesis, fatigue, and really an exam that's not terribly significant or specific for anything. Does anybody want to start us off with differential diagnoses of what might be going on with this patient?
Michael, did she have conjunctival pallor, any kind of symptoms of anemia?
No other significant signs of anemia. The symptoms, the fatigue, the little bit of dizziness, the nausea that sort of went along with the coffee ground emesis. But no, she really looked more or less okay.
And was she orthostatic or they wasn't checked?
They weren't checked in the ER. We checked that morning, and she was within about a point of being orthostatic. So not technically, but almost. And at that point, she'd also received a unit of blood. So
yeah, and it's difficult because elderly patients get orthostasis just from
Yes.
hypertension, so it makes it tough.
So, I mean, thinking about just sort of a slow upper GI bleed, I mean, any sort of like Ern said, use in the past, or this travel history could be some sort of gastritis from whatever. One of those two things.
So history of ulcer disease, think about NSAIDs in an older patient, NSAID gastritis, possibly something being in the Caribbean, something maybe even infectious. What else do we have? What else causes coffee ground emesis in patients?
Peptic ulcer disease.
Yep, so recurrence of actual peptic ulcer disease. So she denies drinking, but she is well functional. Any other thoughts, concerns for this patient?
Stomach cancer, they had hiatal hernia, they had reflex esophagitis, and erosions, maybe even varices.
Sure. So why varices in particular? What would tip you off to that on the physical exam?
I mean, typically they don't. Typically they're bleeding enough to make right red blood. But
Yes. Well, she did have a little bit of abdominal swelling. So an 88-year-old lady, you know, she may have had something sort of indolent for a very long time, may have developed sort of an occult cirrhosis type of picture. That actually covers most of it.
Did we mention Mallory White's tear?
Mallory White's tear, usually bright red, but yes, also if it's relatively slow after the fact, can also cause some coffee ground emesis. Absolutely. All right. Anybody want any particular lab tests on this patient?
I mean, CDC,
Yeah. So initial hemoglobin in the ER is 7, platelets high, MCV only 80.
Do we know her baseline hemoglobin?
We do not know her baseline. She is an otherwise reasonably healthy lady. She sees her outpatient physician that's not with our system, and she goes to a Rite Aid sort of get healthy clinic intermittently as she likes to go every once in a while. Anybody want anything else?
the LFTs and DMP.
Start with LFTs. Anything concerning? No, pretty normal, really. I mean, nothing jumps out there. Metabolic panel. Anybody see anything interesting about our metabolic panel?
BUN.
Yes. And why is the BUN most concerning for this patient? Yes. So BUN will be elevated in someone who's reabsorbing a GI bleed into their intestines. So otherwise, the creatinine, we didn't have a baseline. She did look a little bit on the dry side when she came in, but for someone of her age, not terribly significant or concerning at this time.
No, a creatinine of 1.3 in an 88-year-old lady is going to be quite high, right?
Well, she was actually in very good shape. I mean, she had a reasonable amount of muscle mass, so it was not the most concerning.
Her GFR is going to be low enough to put her at least stage 3.
Oh, yes.
And maybe stage 4.
And we believe that because of what was going on with her, that this was probably a little bit more acute. So, anything else anybody wants offhand?
Probably go ahead and coags.
Coags. Let's see, I believe. Almost normal. Troponins were not done, actually, surprisingly enough. So, those are most of the important labs. So, going on the hospital course. So, she got a unit basically at the door. Vital signs, stabilized, tachycardia resolved. Next morning, GI did an upper endoscopy showing grade 4 esophagitis. They thought that this was where she was bleeding from. They didn't see any signs of active bleeding, and said keep her on a PPI drip for a while and make sure she does well, and go ahead and send her home whenever she's ready to go. So after looking at her that morning and kind of making sure that she was stable and not actively hemorrhaging from a varix or some other cause that require a more urgent intervention, we noticed that her belly had been a little bit swollen, and she'd mentioned going to this sort of Rite Aid, Ready Med sort of place, and she said she started going because she was worried she was getting just a little bit of weight around her belly, and they kind of put her on a little bit of an exercise program and sort of helped her get more active. But when we were examining her liver, it felt pretty large and it seemed a little bit strange to us, so we went ahead and did a CAT scan of the abdomen and pelvis. So if we can hit the lights real quick, these are a few representative cuts of her CAT scan. So you can see a couple of positive arrow and measurement signs, and really a fairly distorted and difficult to read CT scan. It's not abundantly clear where intestine start and this mass ends. Looking at other cuts, again, significantly distorted, with concerns actually for obstruction of the intestine and colon, or impending obstruction and impending impingement on the ureters as well. And here you can see as well is just very significant mass in more than one spot, as well as displacement of the other organs. And so this patient died, actually. And so from this, thank you, I want to take a moment and sit and kind of think about what happens when we have patients who very suddenly are doing well and have a very life-altering or life-ending diagnosis or event. So I want to think about, going forward the rest of this sort of discussion, think about this patient, talking about some of our experiences breaking bad news and discussing that with families and patients, and considering what we can do to improve our approach to it, and sort of make a difference in how we take care of our patients. And so the first question to think about this patient is how this patient died. So how did she actually die? She died in a hospital with some family in the building, but not at bedside. In the larger sense, she sort of died from complications of her cancer. This is obviously very different from how people died even 30 or 40 years ago, when many people passed at home, comfortable, family next to them, not with an entire medical team around them. So it's something that when you ask most people as well, most people don't say that they would like to die in a hospital. Most people die peacefully at home, preferably at a rather old age, of something not very painful. But in this case, it's not exactly what happened. And, the thought whenever you have a patient who you suddenly realize has a terminal condition is, what can you do for this patient to improve their life, improve their prognosis and diagnosis? And it kind of leads in the question of the idea of what is a good death? Is there such a thing? In American culture, it's not really something that's discussed. We are, the culture that created Superman. There is invincibility. There is, people don't talk about death. It's moved to a funeral home. People don't have wakes so much as they used to, and things of that nature. And so the idea of thinking about death and deciding, and having patients think about it ahead of time is something that really is uncomfortable for not just them, but for a lot of physicians as well. And thinking about that again, how do our patients die? Do they die in the middle of lots of interventions? Do they die peacefully? Do they die in the end of a code? And is that what most people actually want? So thinking about this, I kind of want to open this up as why it's important to discuss. So for one, in the obvious sense, we want to do the right thing for our patients no matter what. On top of that, we're going to see this in pretty much any subspecialty you want to go into, and for internal medicine, we see it a lot in a clinic, in a hospital setting, anywhere. We're breaking bad news to people. We're telling them things that are uncomfortable for us to tell in many cases, and not good for them to hear. So the biggest question is, what is bad news? I'm going to open this up to anybody who's brave enough to step up and say, how do you define bad news for a patient?
Maybe a bad diagnosis or whatever, just something that somebody doesn't want to, you expect that they don't want to hear. That's kind of like a really big question. A
bad or poor diagnosis, or something that most patients would not like to hear.
We usually think of it in the context of a terminal illness. Mm-hmm. Sometimes diagnosing somebody with high blood pressure or diabetes is bad news when you're telling somebody that you're going to have a life, condition that requires treatment and monitoring. So it's not always, that extreme.
Absolutely. So, anybody else? What else? What?
Interesting. We just talked about this morning. There's a patient in my office who had new diabetes, took metformin, got sick and nauseated, was convinced it was the metformin, turned out he had mild obstructive jaundice, thought he had gallstones, vernacular stricture, had double duct dilatation, and was just proven yesterday to have adenocarcinoma. And his wife didn't want the gastroenterologist to tell him, and he was meeting with us today, so we sort of prefaced that discussion. Fortunately, it's small, and he's probably going to be able to be cured with the whipple we were hoping.
So, everything from chronic diseases to anything. And really, sort of as they say with pain, bad news is anything that the patient defines as bad news. So, if you have a young patient, they come in, it's nausea, vomiting, you run a pregnancy test, and it's positive, is that good news or bad news? And that is very much a matter of perspective for most people. For some people, it's the most wonderful news in the world, and for some people, it is a tragedy for them. And so that kind of lays it down. It's true. It can be anything as small or relatively small for us to think about as you have high blood pressure, to you have cancer. So watching. So who here has seen an attending, fellow, upper level, anyone break bad news to somebody? Med students? Anybody not seen people break bad news attending? Okay. All right. So from having seen almost everybody has been in on one of those experiences, what's something that went really well? What's something that when you saw an attending do this or do this for a patient, when they knew that this was going to be bad news, what was something you said, I want to do that when it's my turn, when I have to do this? What was something that you kind of took away from it?
I think sympathizing and just acting as if you really do care, especially when there are family members in the room, kind of shows people that you are on a humanistic level as well. And also asking what people know about what's going on is really important, not just directly going in with information that they may not be aware of.
Good. So taking time to empathize, get to know the patient, get to understand what they know about their disease at sort of the outset. That's good. What else?
Being able to really say the bad news, like up front without any euphemisms or, I don't know, it's really easy to sugarcoat those things, and seeing someone be able to be direct and really tell the patient the truth is really important, but not easy to do.
Sure. And, I've heard of at least one case where you had a primary physician and an oncologist and said, this patient has cancer, but I just can't tell them, we're referring you for treatment anyway. Can you tell them that they have cancer? And that's not necessarily the best way to go about it, but there's such things do happen. It's difficult to tell someone that they have a bad diagnosis. So, what else? What else is something that's been done really well? Sure.
Well, just like the one we had today about the person with pancreatic cancer, stuff I didn't anticipate is like you have to go in with already a plan that you would do, and then the alternative, like kind of know both of those things, because they were asking about maybe what surgery would be and like what you would recommend, and to do that research beforehand, like is University of Louisville a good place to send this person? Mm-hmm. Is it good to send them to another place? Would you be able to talk to these people? Yeah, I thought it was really helpful that we knew those answers beforehand. Otherwise, I would never have thought about it, and you don't want to feel like, okay, well, go take care of it yourself and let me know how it is.
Okay.
And that was something I didn't anticipate.
Taking time to research sort of the most medically aggressive interventions and everything in between, sort of, so that knowing ahead of time what all your options are. That's good.
As a follow-up of that, I mean, in a private world, the big bad cancer often prompts high-functioning families to be prepared to seek national referral second opinion. And so buried in what he was saying was be prepared to have that discussion.
Sure.
Because if you make your local recommendation too strong, then their second referral is against you. And go ahead and acknowledge, if they were to travel, the pros and cons of it, and we had that discussion.
That's great. That's great. What have you all seen that has not gone well, or you saw someone do once and said, I hope that I never see that happen, or I hope that never happens to my family? Sort of bad experience that you observed, sort of as a learning experience.
Well, one of the things you can do is not just set your agenda without knowing the patient's agenda. You need to know what's troubling them the most about this diagnosis. It may not be that they're going to die. It may be that they've got a family member that they're more worried about, and that may be their agenda. So it's important to pay attention to their agenda.
Has anybody seen someone go in, say, "I'm sorry, you have cancer," and then kind of walk out?
I've seen the opposite, where they try to answer too much, and it's maybe a little overwhelming to them with how much information you want to provide, and bring comfort to them that they've just heard the diagnosis of cancer, and that's about all they're going to absorb at that time. And then maybe there's a lot of stuff you can't answer, and you want to give something, and it's just like you're not confident enough, and maybe you should leave that to the next specialist, or just be honest with them that maybe this is something you need to discuss with them.
So trying to do too much too early with the conversation and not knowing enough kind of going in, or not knowing everything going in. Okay.
Yeah, that's a good point. I mean, especially conversations like that, they often require follow-up kind of quickly.
Sure.
Even if it's in like an inpatient setting, if you tell somebody like first thing on rounds, then you should, the next time you see them shouldn't be next day on rounds either.
Right. So I can't imagine how bad it would feel to come in and even have a pretty good conversation with someone, very, very nice, very, very well done, well prepared about, some bad diagnosis, and then not having a plan for, okay, and what's our next step, or what are we going to do? When are we going to talk about this again? When are we going to know more about this? Okay. So has anyone seen meetings that have gone terribly wrong, or just sort of overall things that went just the entire discussion, conversation went very well, it was very smooth, obviously people were not happy about the news, but overall it was delivered in a very sort of kind and empathetic manner? Anything that surprised or sort of changed the whole course of the conversation? Okay. Occasionally you will have a conversation where you'll go in, you'll have done your homework, you'll know this is diagnosis, these are our specialists, these are what they have to say, we've already asked them sort of for a preliminary opinion on the radiology or what have you. And you go in, and there's a very different conversation that happens than the one you're expecting. Instead of a primary issue that you feel is what's going on, the patient or their family are focused on something else entirely. So, for instance, we had a patient one time who was extraordinarily ill, end-stage dementia, terrible end-stage diabetes, had bilateral above-the-knee amputations, was doing quite poorly, was losing blood that we couldn't find, and had a white count that no matter what antibiotics we put him on, we couldn't get below 40,000. And the family had refused a bone marrow biopsy. And we were having this conversation with the family that this patient is really not doing well. They've got a lot of sort of terminal diseases, they're not able to communicate with us. And the only thing that they would say is that, I think if we just put in a feeding tube, we would get them stronger and get them better. And the discussion sort of, was one of, well, this patient has really severe dementia, is not able to really communicate with us at all. They're not able to swallow as it is, and they've been sort of refusing food and spitting it out whenever we put anything in their mouth. I don't think a feeding tube is necessarily the right idea for this patient. And finally, we came down and had a big conversation with the family, and she said, "What is this dementia that you're talking about? Is that like Alzheimer's?" And so, very surprising, as you think you're having a discussion, everyone's on the same page about, this patient is extraordinarily ill, and is, in the early stages of active dying, and, that we had not communicated well enough exactly what was going on with the patient. So every once in a while you can go and be well prepared, and those sorts of things still happen. So
one question.
Sure.
Surprise! I changed about halfway through my career. When you're ordering tests that have potential bad outcomes and hopefully good treatable outcomes, let people know up front both possibilities, and you don't have the surprise at the tail end. This gentleman
Absolutely.
This morning, if that's clear each step, this is not a surprise. They tell you what they have, you confirm sadly yes, and you move on to plan. I didn't used to do that nearly as much as I have for the last 20 years.
So traditional sort of methods for talking about bad news and making decisions with patients based on this, before the 1970s and 80s really came about, sort of based on a very old sort of paternalistic, we are the physicians, we will make the decisions, sometimes even without the whole concept that we have now very much ingrained of, we're going to tell the patient everything unless they specifically tell us they don't want to know. We have not just a responsibility but a moral obligation to discuss with the patient openly their diagnosis and prognosis to the best of our knowledge. And after that, sort of went along with sort of beneficence, we're trying to do the right thing, try not cause harm, but it's really sort of flexible based on the provider. So if you were a very aggressive physician or surgeon, you may want to do different things than another. So there's not a lot of consistency along with that. And, what could possibly go wrong with all of those things? And it turns out a lot of people died maybe unnecessarily or died in manners or after surgeries they didn't want or didn't even necessarily need. And that sort of ushered in a more recent methodology of the whole patient-centered conversation, the patient-centered decision-making. Has anyone ever heard of the spikes mnemonic for breaking bad news and sort of making decisions? So you set up, you judge their perception, you ask for sort of an invitation to be frank with them and to share this news, discuss the whole knowledge issue of it, work through emotions, sort of strategize and summarize what your next steps are, which is a very sort of rote but effective kind of framework for discussing things. This was originally done for oncology in the early 2000s. And then the nurse mnemonic is a little bit less common or a little bit less known, but it talks specifically about managing emotions within a conversation, within a difficult conversation. So, I understand that you're extraordinarily upset or sad about this. If I were in this situation, I imagine I'd be very, very upset, very surprised as well. And sort of going from there, what else can we do to help you? What other emotions you're having along with this? And then more recently, this mnemonic of breaks came up, which was really the only other one that I could find. And it's fairly significant to the spikes mnemonic. It doesn't necessarily change or add a whole lot, but it's a slightly more updated version. And so for me, though, I'm a little bit more practical as far as this goes. I think that on one hand, you have an extremely paternalistic, old-school style. On the other hand, you have what's been sort of stereotyped into the Happy Meal, the McDonald's sort of mode, where it's patient-centered and patient-driven, and the physicians are sort of beholden to the wants or demands of the patient, regardless of their medical indication, even. And to that end, to just sort of show what would be appropriate and inappropriate. Not too long ago, there recently came out a study that discussed code status in the middle of a code. And so they reviewed the phenomenon of asking families in the middle of a code if they wanted to keep going, which really is sort of not a great idea for all sorts of reasons. But the most significant being, first, they have, almost without exclusion, no medical experience and no ability to even begin to judge that. They're in an emotional state that obviously would completely compromise most of their decision making. But essentially, the whole idea of we as physicians have the ability to make these sorts of decisions. We're not beholden on a family to say, well, do you want us to keep going or do you want us to stop? It's a physician's decision. And it's interesting that, in some ways that this needed to be published, but in other ways, maybe it's good that it was, because it sort of does redefine that, regardless of maybe a family's wants or demands, if a patient has passed, they've been in asystole for 35 minutes, it's unlikely that another 5 minutes is going to actually help the patient or recover circulation. So I thought it was very interesting how that came out. Also, personally, I'm not a fan of mnemonics. Spikes, I have to have up here. I have to have it sort of spelled out because I can never remember it. Mud piles is a personal dislike of mine. It's very difficult to remember. Some of them are not that practical. And I'm not sure that they help everyone as much as sort of being able to work through and understand things. So I want to talk about some pearls, some sort of practical methods, and then we'll get back to our patient as soon as we're done. So pearls for the practical people. We have become so well educated as physicians that we have forgotten how to talk like normal people. In Kentucky, patients over 40 or people over 40, many of which were patients, 37% did not finish high school. So at best, they are able to read, speak, and understand at what was a 12th grade level, and that's perhaps on the optimistic side. In the U.S., though, overall, it's still 25%. So that's a fairly significant portion who will have a difficult time understanding most of what you say. We struggle to realize how we speak until we start talking with people who have no medical background whatsoever about our daily lives. And sort of referring back to the patient that was discussed earlier, this patient has dementia. Well, I think probably everyone would think, well, dementia is a fairly common, most people, if you say dementia, people will understand roughly what that is at least. But no, is that like Alzheimer's? So we must be very careful that when we're explaining things that we make sure that our patients understand them in a working sense and not just sort of, oh, sure, I'm sure they've heard of what this word is. Framing is everything. So when you go into a discussion with a family, how you approach the discussion may determine the outcome. And there's an entire industry to say this, most of it coming out of sort of politics and advertising. How you begin a conversation, how you sort of set up the discussion vastly changes the outcome. So the perhaps most common example is if you talk about code status and you tell a patient, well, if your heart stops or you stop breathing, would you like us to restart it or to try to restart it? Well, sure, why not? What do I have to lose from that? On the other hand, you see some residents saying things like, well, if we do CPR, it's going to break some of your ribs. We're going to put a tube down to help you breathe, and you'll probably be in the ICU for a few days. That's much less attractive to most people. And while either one may be appropriate considering the situation, both of those are very much on the extremes and probably tailor your outcome fairly significantly.
Dr. Earnshaw, who's in palliative care, told me that she feels like the breaking, the ribs and that tube and stuff is almost never an appropriate way to talk about it.
Right.
I agree with that too.
And it is a medical intervention, and it is something that we should essentially have informed consent for because it's generally not considered to be a benign intervention either. But at the same time, being aware not to use what some people might consider scare tactics or be sort of glossing over it is very important. So, and then this is a quote that I love there. In front of us, behind us, we're flanked on both sides by an enemy that outnumbers us 29-1. They can't get away from us now. And the whole point is that there will be conversations, if you haven't experienced them yet, where you'll go into a conversation, you'll be fairly prepared, you'll be fairly ready, and you're going to walk into an ambush or something that you never expected. Extraordinarily angry family, extraordinarily confused family, a family whose family members kept everything from them, and they only now discover that they've had this end-stage disease for many, many years that they've just not told anyone about. And at that time, it's important to realize that no matter how angry they are, and really the more angry they are, the more they need someone who can actually help them get through this. The more difficult it is for them. And that's something that I feel is sometimes difficult to keep in mind, and all of a sudden families demanding different interesting answers about why they weren't told about this, about, where did you go to medical school, or even old enough to be a doctor, those sorts of things. So just be aware that when you do encounter a lot of unexpected resistance, is actually probably when you're going to have the biggest opportunity to impact a family. So thinking about mnemonics that are more useful perhaps, if you can memorize the 5 Ds of dodgeball, you can get 5 Ps for palliative care and difficult discussions. So first, understand that the entire part of this is a process. So you are initiating a process of grieving for this patient. They now have information, knowledge, diagnosis that they did not have. Avenues of their lives have perhaps closed forever for them. They may not see their grandchildren anymore. They may not be able to go on that cruise or go on that vacation. They may not be able to walk. You are beginning this process of grieving for them on a life that they no longer have the opportunity to live in some regard. And understand that it takes time and it changes along the way. The family's reactions may change. And that it's in part your job to try and help them through as best that you can. So if you can pick one thing to do, plan what you're going to say, plan what you're going to do. So know everything about the patient you possibly can. And in some cases you know nothing about the patient, and all you know is they showed up into the ER and they've asked you to come evaluate this patient who looks terribly sick. But as much as you're able to, get the history, get the background, find out who their family is, what's been going on. Maybe they've already had significant discussions with palliative care. They have a complete advance directive, living will, all of this, extraordinarily well thought out, and maybe they have thought of nothing, and every time the family's brought it up because they know they've been sick, that they've sort of brushed it off and said they didn't want to talk about it. So people, if you can have consultants there, if it would be helpful, that's sometimes difficult to do. Family members are great to have there. If there's someone in the family who has medical training that they really want to be there, those sorts of things are important because they have a significant input on the decision. You want to be there to sort of answer those questions ahead of time for them. So perception. So when we see a patient and we make a diagnosis that is terrible or that is terminal, we get a vague perception of what their prognosis is. So, we have statistics that say if you have such a stage cancer, your 1-year survival is approximately this percentage. Your quality of life after the necessary surgery is going to be this. Their perceptions, because they have no medical training, are going to be very different. It may be sort of undershooting. They may not think this is quite as bad. They may think, it's just an infection in my leg. What could possibly be wrong? Well, it's deep into the bone, and we're going to have to recommend that you have an amputation of your leg. Those sorts of things are vastly different. Or they may think, I have cancer. We have stage 1 basal cell cancer. It's probably going to be okay. But all they heard was, I have cancer. So it takes some time. And sometimes it's very easy. Sometimes it takes many days. Sometimes it takes weeks. Sometimes it never happens that you reconcile sort of the medical reality with what their perception of their health was and is. And then finally, remind yourself that this is a process. It takes time. It is your responsibility to help them through this, and not just in sort of the long definition of it's a process over time, but they have to emotionally sort of process this information. You have to understand what you say now. I think somebody said earlier, when you tell someone they have cancer, they tend to stop listening quite as closely to the rest of it. It induces a state of shock that it's just very difficult for them to think or hear anything else.
Let me reinforce that point, that the
Yes.
people in this field have made the point, and that I went to a national meeting on this, and that sort of surprised me. But the point being that you get better measurable understanding if you say, if you were to have cancer, this would be your plan. Now let's look at your results. Yes, you do, as opposed to you have cancer and let's do this. I think there's some truth to that. Mm-hmm. In my own practice, again, this is a process in steps, so I don't find that a big problem. But the national people in this field have made a big point about that.
Sure.
And in your setting where you're walking into people you don't have ongoing relationships, there's probably more truth to that.
And occasionally you do have that luxury. So if you've met someone for GI bleeding and weight loss, you could have, especially if they're over 40 or 50 years old, you should have a reasonable suspicion that maybe they could have a cancer. And that's an important conversation to have ahead of time. You know, we're going to have the GI doctors come and talk to you. We're going to talk about having a scope and going to see what's going on. There's a chance that this could be a cancer, and we should talk about, you know, what our options are if it is. So you can sort of, you know, even though a lot of times in an inpatient setting we have really no opportunity to do that, occasionally you do have that luxury. It's important to try and do as much as possible, sort of set the expectations, sort of preface and prepare the patient before they actually receive bad news, if you feel that it's even remotely likely. And so what happened to our patient in particular from earlier? So even the radiologists were unsure, but their best estimation based on the imaging said she had stage 4, probably ovarian source, with carcinomatosis, impinging on the ureters and on the colon, but not completely at this time. We sat down that afternoon, sort of discussed that with the patient, talked about sort of what that means in the bigger sense of things, and decided with her that the best thing to do is have gynecology, oncology come, talk about options, prognosis, palliative measures are possible, and then in the morning have palliative come by, talk about sort of what other things are available, because, you know, for the stage 4, the options, relatively speaking, are somewhat limited, especially in a lady who's this elderly and has such an advanced disease. Unfortunately, though, that evening I got a call home from one of our cross-covering residents, and this patient had aspirated, became hypoxic, and coded and died. On the fortunate side of this, she'd had family visiting all afternoon. After she found that out, she had a lot of her family who lived in the area come by, and they were able to sit and talk for several hours. But, you know, still it's sort of a very difficult situation. You know, what do you do for this patient? What do you do better? But the biggest thing is, if you're not sitting down and trying to talk to patients really about this, the importance is that no matter how they look relatively stable, they are, you never know what can happen to them. And so being able to have even that little bit of time, I'm sure, is a great comfort to her family and to her. So with that cheery note, any questions, discussion, comments?
I'd like to add one thing to the slide where you started out talking about health literacy, general literacy, health literacy,
yes,
and medical jargon. One thing that I figured out somewhere along the way, and this was because my husband told me this, is that it's not just medical jargon, but there are certain words that you've probably worked into your vocabulary that you don't think of as medical terms, that the general public does not use. So the two I've found that I'm the most guilty of are using the words decompensate and exacerbate, which are not technically medical words, but words like that that have a medical connotation to them. So I think you also have to think about, there are even some of my clinic patients who I will use the word elevated with them and realize that there's not understanding. So it's not just medical jargon you have to worry about in these discussions. It also really is talking with the general vocabulary that people can understand, because that brings back the point to the dementia.
Yes.
Which actually is a medical term, but it's something that you think of as lay people, really
in the popular media.
And so, so you have to really, if you have concerns about this, or it's your first time breaking bad news, etc., you might even need to think about that ahead of time. Exactly what words would you choose? One thing that really helped me as a student and resident was to listen very specifically to the words that my role models use and use those as a script. Not that you don't have to change them, but that really helped me to have some scripted ways of saying things that I could model my words after, so that I would avoid saying things in a way that, either just wasn't the best way to say it, but also could be inappropriate or maybe using medical terms that I didn't even think were medical terms.
So I always recommend that, if people want to really figure out how much they sort of lost the realization of, if you have little cousins, nieces, nephews, 5, 8, 10 years old, try and explain to them anything. Kidney failure, acute pancreatitis, anything, it doesn't have to be anything, it doesn't have to be anything rare, terribly complicated, but just something like that. If you can, next time that you have a patient with pancreatitis, ask them what they understand about what's going on, what's actually causing it, because they know what causes it, they know what makes it get better, and they usually know when it's coming on and when to go to the hospital. But you would probably be surprised, I know that I was after I started talking to some of them more, how few of them actually understand anything about their actual disease at all. And it's kind of eye-opening to how poorly sometimes we communicate and how we can try to be cognizant of that and do better. So.
A few weeks ago I discovered a hip-hop blogger, parody video maker who's a doc, a Stanford trained ZZ Dog MD. And for people that haven't looked at it, I would suggest you look up his Ain't the Way to Die one that he did. And on a different note, look up his electronic medical record one. But on this topic, that Ain't the Way to Die is an incredibly touching spin on this.
So last year when we did the Teach Back module, there was a plain language dictionary that I sent out as part of that. So I can put that on the Google Drive as a reference for us. But my husband, who's interested in quantum physics, whatever, I asked him some of the questions. And so, interesting, I said, what about prophylaxis? He's like, why are you talking about condoms? Because that's what we called it in college. And I was like, no, that is interesting that vaccines are not, people who are educated make very, very different things, and things like Dr. Cook was saying, like elevated, like is up, and things like that. So I can put that on the Google Drive if you guys want me to put that on there. And the other thing that they taught us when we were starting our palliative care fellowship here is, and one thing that Michael didn't mention, is that you should give people a warning shot. So not, hey, you got cancer, or I have some news for you, and then ask who they want to have there with them. So like some people. One thing that was very surprising to me because of my personal background was that some people don't want to know, which to me was completely foreign. And so you ask, who would you like to be here with you when you're breaking bad, with this news, or do you even want it? So some families didn't even want to know what it was. So that happened to me at the VA doing hospice, is that there are some cultures in which you do not tell the patient directly. And so I had to learn to ask people, do you want to know, or do you want someone else to know? And that was very uncomfortable for me. But once I figured out the patient really wants that and that's culturally acceptable, that was okay. But I did not understand that really until I had experienced it.
In the second, the setting the terms in what you do with this gentleman this morning, I moved some people in the schedule to make sure that we wouldn't be rushed.
Sure.
I confirmed that we knew his wife was coming and controlling the circumstances.